My name is Ed Beveridge. I'm a psychiatrist. I work with the UCLP mental health team, and I was one of the clinicians who helped develop the clinical model for UCLP Primrose. This is a short video to help you decide how you implement the model locally. I'm going to tell you a brief bit about the model. I'm going to talk you through the algorithm in more detail, and then I'm going to show you a way of determining who does what within your local area to help you to decide how you implement the model. I hope it helps. Please bear in mind there's really extensive information and training materials on our UCLP website, and we'll make that available to you too. So this is very much a brief guide on how you might decide how to implement. Just a brief description of UCLP Primrose. You're aware that people with severe mental illness like schizophrenia die younger than the general population. 10 to 20 years is often said, and sometimes that's due to them not receiving the preventive or therapeutic physical health care they need. This is a priority for the NHS and also for integrated care systems. UCLP Primrose is a pathway intervention that transforms your care of patients with SMI. The package is a number of measures which enable you to identify the people who are at highest risk of early death so that you can provide evidence-based physical health care to them, to identify people not currently engaged with care and offer them outreach, physical and mental health supports, and to provide behaviour change interventions which both improve mental health and support people with attaining physical health and well-being goals. It's got three components: risk stratification and search tools, materials to help you undertake the SMI physical health check, including a clinical review to ensure people get the best evidence-based physical treatments, and materials and training to support people in providing behaviour change interventions. I'm going to share my screen now, and you should hopefully in a moment be able to see some slides come up on my screen. So this is the UCLP Primrose model, and I'm going to talk you through it very briefly. On the top, you see 4 priority boxes in dark red. I'm colorblind, so apologies if they don't look dark red, but that's what they look like to me. This is the risk stratification. So you will be able to run a search on your SMI register, so all the patients with an SMI diagnosis within your practice or PCN, and it will put them into 4 priority groups. The first one, priority 1, is people with identified long-term conditions which are poorly controlled. The second one is people who are not engaged with care because they've not had a blood pressure measured for 18 months or more. The third group, priority 3, are people with long-term conditions that are better controlled than priority 1, and priority 4 is the rest of your SMI register. The idea is that you run this search to identify the people who are most in need of a physical health check and interventions and people who are not engaged at the moment. They're the people who you prioritize for the rest of the intervention, but in an ideal world, everyone would get the intervention in their priority group order. If you look at the left-hand side of the model, what you can now see is a process for providing the health check, clinical review, and intensive behaviour change intervention. So once you've run your search, you invite people for their health check, and if they engage, we're going down the left-hand green side of the algorithm. I'm pretty confident that that's green. So the physical health check is undertaken. This may or may not already have been done, or elements of it, but we provide some materials to HCAs or other professionals doing the health check about how to do it with a view to working specifically with people with severe mental illness. They then have the clinical review. So that's usually with a prescribing clinician, a pharmacist or GP. That's aimed at optimizing their treatment for their long-term conditions, i.e. providing treatment for their most highly modifiable cardiovascular risk factors. And following that, there is the intensive behavior change intervention, or the Primrose intervention as we call it, which is aimed at providing a series of appointments where patients set health and well-being goals and are supported in attaining them. To the right of the bottom green box is a light blue box labeled wider social support. This acknowledges that most people with severe mental illness will be dealing with a number of other problems, and they might prioritize these over their physical health. especially if it's things like housing or finance, which at the moment, at the time of recording in 2023, are really very much on people's minds. So this acknowledges that there may need to be involvement of people within the wider system, be that social prescribers or people from the VCS, care navigators, citizens advice, you know, the wider sort of support ecosystem, who actually could become involved with the help of the intensive behavior change support workers to meet those patients' other needs. Now, looking back at the algorithm, you'll see that on the middle and right hand side of the model, we have boxes in navy blue. This is to acknowledge that there are some people who will not engage with your initial invitation. So say you get somebody who's in priority 1 or priority 2, you invite them for their health check and they don't attend. We work on the assumption that this probably means a number of things, one of which is that the patient is mentally not that well. These are patients with relapsing and remitting conditions which can make them very poorly. So we've incorporated what we call the mental health review, which is ideally undertaken by a mental health professional such as a nurse. They will look at the patient as a desktop review initially to determine what they think might be going on with their mental health and to make a plan around that. It might involve inviting them to see the mental health nurse for a review of their mental health, and that might result in a referral for mental health treatment. It might even result in something like a referral to crisis team or for inpatient care if someone's really unwell. It's likely that some patients will require a degree of outreach. So if they're not responding to your usual invitations for appointments, they might need the mental health nurse to collaborate with others to go and see them at home or to outreach them in some other way. And as we've said, there might be some need for specialist support. Overall, the idea is that you want to move anyone who's situated on the right-hand side of the algorithm, i.e. not engaged, to be able to move over to the left side of the algorithm because they've been supported to get well enough to do so. I'm going to stop sharing. That was a very brief outline of the model. There's much more information in our materials about that should you be interested in looking at it. So I'm now going to share another image with you, and this time it's another version of the algorithm that you just saw. But what you can see this time is a number of additional boxes on it, additional fields. What we found is that when people start looking at implementing the model, it helps to really go into granular detail about who is doing what, because this varies widely from place to place. It depends on what staff you have, what additional roles you have, what your relationships with other providers in different parts of the system, such as mental health or voluntary sector, are. So we found that looking at the algorithm and understanding that is one thing, but actually spending time mapping your bespoke local processes is the thing that makes a real difference. So I'll just talk you through how we do that. And we'd suggest that you use this annotated version of the model and create your own process map with the identifying who does what stage is the thing that really tends to help. So if we look at the top right and work our way around to the bottom right, that's probably the most sensible way to do it. So we start with the search tool and thinking about who runs it. Some places that will be your practice manager, some places that will be an admin, it will vary. And then you need to think about what do you do with the search results, because you'll come up with a list of your patients in priority order. You need to think about what you do with that information. Who does it go to? Who needs to see it? And who then invites people for the next stage? So this can be an admin process, but that will vary from place to place. So next you need to think about, on the basis of the stratification, who sends out the invitations to the health check? How do they do it? What's the mechanism whereby they invite people to come along for their health check? So you'll be able to see that we've said, is this a letter? Is this a call? Who invites them for their mental health review and when? How many times? How many goes are you going to have at inviting someone before you determine that they're not engaging? For the cohort who engage, you then need to decide who does the mental health review and indeed who performs the outreach. Is there scope for going to people's homes, for example? We then need to look at who does the health checks. Now, often this is a part of your offer that already exists. So there'll often be a healthcare assistant, maybe even a nurse who does the SMI physical health checks within your locality. So you need to think about who does that, how they invite people, what they do with the output of those checks. How are they going to invite people for a clinical review, especially if there are concerns within their physical health check results? How will they feed back results to the patient? How will they set up the next appointment? How will they make sure the process runs into the next year? Because remember, this is something that happens annually. So you need to think about what your processes are for that and who does them. Then you need to think about who does the clinical review. And this could be a GP, it quite often is, but it might also be a prescribing pharmacist within your PCN or practice, or it might be somebody else within your locality. So you need to think about who does that. Might be a specialist nurse, prescribing nurse. It will depend on who you've got locally. They will then perform their medicines optimization intervention, and then they will decide who gets invited for the intensive behavior change process as well. So you then need to decide how clinicians are going to invite people for the intensive support element of the process. And it's important to think about whether the wider workforce are aware of the Primrose intervention. So do your social prescribers, do your pharmacists who might be doing medicines reviews know about this process? Do they know it's happening? Need to think about how you're referring people on for the behavior change intervention. How are those referrals being made, and so on and so forth. Obviously, that involves deciding who locally is doing your behavior change intervention. So some places that's a health and wellbeing coach, some places that's a specially trained HCA. It might be the HCA who does a physical health check. It might be somebody else. Might be somebody from the voluntary sector. So some parts of the country, we've got very good input from third sector organizations who are very happy to be trained to do this behavior change intervention. And it might be people with lived experience, such as peer coaches as well. So you need to think who's doing it, what's the referral process, how are they recording their appointments, and so on. And then we need to make sure that the people doing the behavior change intervention also know how to refer on for wider social support. So do your social prescribers, care navigators, and other people in the wider system know about the Primrose intervention if they're going to get a referral for that? So far, so good, hopefully. You need also to think about the non-engagement side of the algorithm. So very important to think about who's doing the mental health review. Is this someone from your core mental health team? Is this somebody embedded in secondary care? Is this somebody in primary care? Who is the best person to do this? And what do they have the access to the right systems, and so on? It might be that they need support with their outreach. So, for example, it might be easy for them to see a patient at your surgery or within the core mental health team. But if they determine that someone needs a home visit, they might need additional support around that. Often that might be peer support. So you need to think about, have you got peer support workers who could collaborate with the mental health nurse to do outreach? And that will very much depend on what your local setup is. So I guess another question in our annotated version here is, do people from your local core teams or specialist services know about UCLP Primrose? Do you have a way of communicating with them about people you identify as having additional mental health needs? Do you have a referral pathway for people who might need crisis support or specialist mental health support, and so on? Those pathways will exist, but you need to sort of think about locally, how do you make sure that your Primrose clinicians and mental health nurses have good access to those pathways when they need them, so that we can get people into the left-hand side of the diagram. Finally, this box, which I think might be green as compared with the other ones, you want to think about your outcome measures. So how are you going to measure that the right people from the right priority groups are going through the right bits of the pathway? What outcomes might you want to measure? Are you going to look at whether your health check outcome improves? Are you going to look at some other measures? That's going to be, are you going to use something else like Dialogue Plus, people's satisfaction with their physical health? There are many ways that you could think about measuring outcomes, and there's more information about that in our materials. That's all I'm going to say. I hope it was somewhat helpful. I would encourage you to use the annotated version of the algorithm for process mapping sessions, because in other places we work, this has been really helpful. I'm going to leave it there. Good luck. I hope it's fun, and I hope it really helps your patients, and please refer to our materials for any other questions you might have. Bye-bye.